I have the pleasure of introducing our speaker. Dr. Hawthorne earned a MD from the University of Kentucky College of Medicine and completed residency in psychiatry at the University of Kentucky Medical Center. He is board certified in psychiatry and addiction medicine and currently serves as associate professor of psychiatry at UK. There he is involved in a resident and medical student education, serving as program director for the Addiction Medicine Fellowship and assistant program director for the psychiatry residency. Additionally, he provides treatment for substance use disorders at UK Smart Clinic and Beyond Birth Comprehensive Recovery Center. Welcome, Dr. Hawthorne.
Hello. I guess it's still morning, so good morning, everybody. Somebody had just private messaged me in the chat, so I was just waving hello to them individually, but good to see everybody here. All right, so yeah, we're gonna spend about the next hour or so talking together about medications for opioid use disorder. And I understand there's a lot of different folks in the audience today from different professional backgrounds and different kinds of work with patients who have substance use disorders. So I'm gonna try and keep it relevant, hopefully for everybody. So hopefully it's something everybody can walk away with and be useful today. I have no relevant financial relationships to disclose. So yeah, why are we doing this? So I mean, if you're here, I mean, you probably already know that opioid use disorder is a huge problem in the community that we treat here in central and eastern Kentucky. Commonly encountered clinical condition with high levels of associated morbidity and mortality. So, disease and risk for death, right? And we're going to spend today talking about medications for opioid use disorder, which are effective treatments for this condition, but probably underutilized, and that could save lives and improve quality of life for folks who have opioid use disorder. And increasing access to these could lead to significant outcomes, improvement in outcomes for patients with OUD. So what are we going to do? We're going to talk about Naltrexone, Buprenorphine, and Methadone as being evidence-based medications for opioid use disorder. We're going to talk about how these work, the efficacy of these medicines, side effects, just some specifics about how the medications are used and how they can be a benefit to patients who have this condition. And hopefully you'll feel a little bit more comfortable about knowing how these medications work. If you're a prescriber, how you could use these in your practice. If you're not a prescribing provider, you could be maybe a little more comfortable about discussing these with patients or referring someone to treatment with MOUD. So we could just begin with talking about a sort of hypothetical case that's really kind of a amalgamation of a lot of different patients that we've seen here over the years. So a 25-year-old guy, comes to your clinic or, whatever service you're operating. He was just released from the hospital. He was admitted there with endocarditis that was related to IV drug use. He'd been using opioids for several years now, began in his early 20s. He'd been injecting for about 2 years. And, drug of choice is opioid pain medications. But when he can't find that, he'll use heroin and lately fentanyl because that's pretty much all that's available. He's experimented with some other substances in the past, but opioids have always been his drug of choice. He's, from a medical standpoint, in addition to recently having had endocarditis, he's positive for hepatitis C. And when you do a drug screen, he's positive for both morphine, which is a heroin metabolite, and fentanyl. In the hospital, he'd been treated for endocarditis, and as he's recovered from that, at least well enough to leave the hospital. And he also went through some medically managed withdrawal, so some detox in the hospital. But no other treatment was begun. And since he left the hospital, he's had severe cravings, and pretty soon after he left, he resumed daily injection of heroin, something that he thinks is heroin, which is probably heroin and fentanyl. He's attended a few meetings, thinks they might be helpful, not really sure. He really is, wants to enter long-term recovery. He's afraid of what might happen to him if he doesn't. He's had these recent health issues. He's had 2 people in his circle, die within the last year from fentanyl overdoses that were unintentional. Wants to quit, but has not had success yet. And so that's the kind of person I think that we see a lot. Not always with every single one of these medical conditions, but this is a fairly common kind of presentation to folks we're seeing, and I'm imagining that you're seeing similar folks too. So, what would you do next? Like, would you consider starting MOUD, medications for opioid use disorder? If so, what would you hope to see? And which medicine would you choose for this person and why? And so you may already have thoughts about this, and you may already have the answer in your mind, but hopefully by the end of the talk today, you'd have a little bit more information to kind of base that answer on and feel a little bit more comfortable recommending an evidence-based medication for opioid use disorder for this sort of patient. And as the case kind of, illustrated, overdose is a serious problem in this population, accidental death by overdose. And that's due to a lot of factors, but this graph kind of summarizes a lot of what's gone on over the last several years. Prior to the pandemic, it looked as if overdose deaths were kind of plateauing and maybe even decreasing depending on what substance you were looking at. But since then, things have continued on this upward trajectory of more overdose deaths. And a lot of that's been driven by this blue line here, that sort of skyrockets up the chart, which is overdose deaths related to synthetic opioids other than methadone. So that's mostly fentanyl. And this may be no surprise to anybody here, but this is a lot of what we're seeing in our population that we treat, right? Is that fentanyl seems to be the primary opioid that's available illicitly right now. It's being sold as any number of different things. It's being sold as heroin. It's being pressed into pretty convincing tablets that are sold as oxycodone or as benzodiazepines. And it's a risky thing, and that's kind of what's been driving this increase in overdose deaths over the last few years, combined with all the disruption associated with the COVID-19 pandemic that probably had a part in it as well. But this is one outcome, right, for this patient that we're talking about that you would hope to prevent, right? You would hope to prevent an overdose fatality. And he's at pretty high risk for that. He's using fentanyl, seems like unknowingly. He's injecting, right? He has medical conditions that might put him at increased risk of accidental death by overdose. So there's a lot of risk factors for this person. The good thing about treatment, like medications for opioid use disorder, is at least with buprenorphine and methadone, there's an overall 50% reduction in all-cause mortality. So you can reduce his risk of dying from any cause, including overdose, by 50% with these evidence-based medications. Going along with that, there's evidence for all kinds of other positive outcomes. And we're going to talk about these things in a little more detail. But these medications decrease use of illicit opioids. They decrease injection use. They can decrease infectious disease risk, so acquisition of like HIV and hepatitis C. They can improve retention and treatment, improve overall functioning, reduce involvement in criminal behavior or criminal activity. And, so there's a lot of possible outcomes, and this varies from medicine to medicine a little bit. We'll talk about that later in the talk, but overall, there's a lot of potential positives for these medications in addition to the reduction in mortality. But despite all this, these medicines are underutilized. There was a recent large-scale retrospective review, which was I think from 2020, that had found that in their data set, which was large, they of the patients who had opioid use disorder, only about 15% were receiving any kind of FDA-approved medication for this. Most of those folks were getting buprenorphine or methadone, and a smaller percentage were getting naltrexone, but really underutilized, right? Especially given the fact that we know this is a disease that has a significant level of morbidity and risk of death as well associated with it. So really underutilized given what we know the medicines can do. So we're going to kind of move from that. That sort of sets the stage to talking about what do these medications do individually, like how do these work, right? Well, they all target the same receptor in the brain. So they all target the mu opioid receptor. And so that's the main receptor in the brain that's involved in opioid addiction, or opioid use disorder, I should say. And so, but they do it in different ways, right? So this receptor is the receptor that, when stimulated, leads to pain relief, but also in the context of opioid use disorder, leads to euphoria and the sense of being the intoxication that comes with illicit use. So each one of these medications hits that receptor, but does something different. Methadone, over here on the left, and we'll kind of use the analogy of like an electrical outlet here, right? Methadone plugs into the outlet and delivers like, or receives, I guess, or delivers 100% of the charge, right? It's just as if you're normally plugging something into an outlet. So that's one end of the spectrum where it's hitting the receptor, it's occupying the receptor, and it's stimulating that receptor with 100% activity. It's a full agonist, is what that's called. On the other end of the spectrum is naltrexone, right, the far right here. And this medication occupies the receptor, sits in the outlet, so to speak, but doesn't do anything, right? So kind of like if you have a toddler at home, you're familiar with these little plug covers that cover electrical outlets so that, your child can't, can't put anything in the outlet and accidentally harm themselves. Naltrexone is a similar kind of thing. It occupies the receptor, but doesn't do anything. It just sort of blocks access to the new opioid receptor. And in the middle is buprenorphine, which occupies the receptor and binds tightly to it, but works at about 40 to 50% activity there. So it's sort of like you were plugging the outlet in here, but through a power strip that reduced the energy flow or something like that. It's partially activating the receptor. Another analogy could be it's like a dimmer switch. It's not on or off, but it's sort of like it has the ability to turn the lights on, but not all the way on, 50% on, something like that. So we've got a spectrum here of medications and how they work at the opioid receptor. And we'll talk, and to understand kind of like, what that means and how that might help in substance use disorders and opioid use disorder, it's useful to know just at least a little bit about like what happens in the brain in addiction, right? And so, the thinking is that addiction is primarily a brain disease or brain disorder, right? That's where, the brain functions in an abnormal way. And that's been, well established to follow this pattern, right? That is demonstrated here on this picture, and we're going to talk about what that means. So it's a cycle, right? So the brain gets into this cycle of three phases that represent the cycle of addiction. First part of that phase is the binge intoxication phase, and this is the high or the euphoria that patients feel when they use an illicit substance. And for our patient, it's heroin or fentanyl. That's followed by a stage of negative withdrawal and negative affect. So this is like the crash and the withdrawal symptoms and the dysphoria and the anxiety and restlessness that can occur after a patient's used, and they're coming down, so to speak. That leads directly into the third phase, which is the phase where the patient becomes focused on using again. So preoccupied with use, experiencing a lot of craving, and ultimately using the substance again. This is all driven by changes in the brain that are a response to exposure to the drug of abuse, so the illicit drug. Again, for our patient, for purposes of the case, we talked about heroin or fentanyl. So what happens in that binge intoxication phase for our patient is that he uses heroin or fentanyl, right? And that activates the reward system. So it activates these deep brain structures. It's the nucleus accumbens to ventral tegmental area dopaminergic pathway, if you want to know kind of the term for it. But it activates the reward pathway, and that floods the brain with dopamine, which results in this feeling of being high. But the brain doesn't like to be out of balance like that. So what it does is it starts to do a few things, right? The brain turns down that reward pathway, kind of turns that down. It also, at the same time, turns up stress systems that are ordinarily, less active than this. And so what happens when the substance is gone and the high is over and the intoxication has passed is that the patient is then in a point where their reward pathway, the thing that helps them feel good, has been turned down. And the stress systems, the thing that makes them feel anxious and restless and dysphoric and fearful and all that, are turned up, right? And so that's that second part of the cycle here. And pretty quickly, as addiction progresses, the patient will tell you, like, I'm not really using to get high anymore. I'm using just not to feel bad. So they move from that sort of positive reinforcement that can occur in that first part of the cycle into negative reinforcement, where getting rid of those bad feelings drives their continued use. And then the third phase, is where the patients experience a lot of craving. There's changes in the brain that lead to that as well, and the structures in the brain that are involved in like controlling impulses and decision making aren't functioning as well either. And so they're in this situation where they don't feel good, they're craving, and they have limited ability to control what's going on, and so they end up using again. All of this driven by changes in the brain that are a response to exposure to the substance of abuse. But the medications we talked about can help interrupt this cycle. And that's why it's important to know just a little bit about it, right? So for purposes of this talk, we're going to keep things a little simple, but naltrexone, because it's a blocker, right, can interfere with that first part of the cycle. So it can block the receptor. It can prevent something stimulating the receptor there and leading to that intoxication, leading to that high, right? Methadone and buprenorphine can do that, and they also can help decrease the withdrawal and negative affect that occurs in that second part of the cycle, because they stimulate the receptor, right? They can help restore some of that balance that has become unbalanced that we talked about just a second ago. And so the end result of that is that buprenorphine and methadone, in addition to occupying the receptor, preventing a high, preventing an intoxication from occurring, also decrease withdrawal, decrease the negative feelings that go along with that, and they decrease craving as well. And so what these things can do is allow the patient time to recover, time for their brain to recover, time to focus on functional recovery in their life as well. So that's just a little bit about the neurobiology of the cycle of addiction and how these medications can help interrupt that cycle of addiction. And so we can move on now just to talk a little bit about each medicine individually, how these things work, what some of the evidence is to support their use, some useful things to know about risks for taking the medication and how these might be used in a clinical practice. First one I'm going to talk about is extended release naltrexone. So this is like I mentioned earlier, it's a receptor blocker, right? So it's high affinity, means that it binds tightly to the receptor. Mu opioid receptor competitive antagonist. It's a long phrase. Basically, it binds to the receptor tightly and keeps other things from being able to bind to the receptor. But again, doesn't do anything at the receptor. It has no intrinsic activity there. So patients are not going to get high off of using naltrexone. There's really no, they don't feel much of anything really when they take it. Doesn't treat withdrawal. It doesn't really reduce craving. But does not cause withdrawal when stopped either, which is, as we'll talk about, kind of a double-edged sword, right? So that sounds positive, right? That, you don't want to have to worry about a patient going into withdrawal when they stop their medication. But the flip side to that is that means that this medicine does not maintain tolerance on opioids. And so patients, when they suddenly stop taking this, if they're not in a good place in their recovery and they return to use, can be at increased risk of accidental overdose because their tolerance has decreased over the period of time they were taking extended release naltrexone. It has demonstrated some benefits, that are evidence-based, and including decreasing illicit opioid use and in keeping people in treatment, at least as compared to treatment as usual, which means treatment that does not involve medications for opioid use disorder. Here's a graphic representation of these three medications and their level of activity at the receptor as compared to their dose. So on the x-axis here, there's a dose of the medication, and on the y-axis here, there's the how much does it stimulate the receptor, the intrinsic activity at the mu opioid receptor. And so with the triangles down here at the bottom, this is naltrexone, and no matter how much you give, it binds tightly to the receptor, but has 0% stimulation of the receptor. So there, as I mentioned, there is evidence to support its use in this population. So there was an interesting study that looked at had a 6-month follow-up period comparing extended release naltrexone to treatment as usual. And again, treatment as usual means no medications for opioid use disorder. So it was a combination of like psychosocial interventions. But they did have positive outcomes here. So the medication demonstrated a longer time to return to use. So it doubled the amount of time that on average before the patient began using again, from 5 weeks in the treatment as usual group to almost 11 weeks in the extended release naltrexone group. So of those who did return to use, it took them longer. They were in treatment longer, about twice as long before they did. It demonstrated a lower rate of return to use also. So 43% of the folks who were receiving the medication, the extended release naltrexone, returned to use over the course of the study, over the course of that 6 months, while 64% of those who were in the treatment as usual group did. So a pretty substantial reduction there of 20 something percent reduction. There was an objective measure of that as well. So they looked at drug screens, and 74% of the drug screens in the active treatment group who were taking extended release naltrexone were negative, whereas 56% of those in the treatment as usual group were negative. So substantial increase in the number of negative urine drug screens. But this wasn't sustained after the medication was stopped, right? Which is not terribly surprising. So when they followed up at 52 and 78 weeks, there really was no difference in the recovery of the patients who had received extended release naltrexone and those who had treatment as usual. That's not terribly surprising. You wouldn't necessarily expect a medication to have effects a year after it was stopped. This is a chronic condition that we're treating, right? So like anytime you're treating a chronic condition, it requires ongoing treatment to have a sustained benefit. So it's approved in its extended release formulation. There is an oral formulation, like a once daily pill of naltrexone, but the actual one that's FDA approved for opioid use disorder is the extended release long acting injectable form. Trade name is Vivitrol. And this has been approved for over a decade now, and it's approved for a very specific indication. That's prevention of return to opioid dependence after medically supervised withdrawal. So what does that mean? Patient has to go through detox or medically managed or medically supervised withdrawal off of the opioid they were using, and then they can begin extended release naltrexone, and it will help maintain complete abstinence off of opioids. That need to completely wean off of opioids that the patient has been taking is difficult, right? Because it's in an uncontrolled setting, especially, that's hard. So if it's in an outpatient setting, it's difficult sometimes for patients to begin this medication because it's hard for them to comply with the 7 to 10 or even 14-day period of time that they need to be off opioids before they can begin extended release naltrexone. The risk there is if you begin it too soon, because it binds the receptor but doesn't do anything, you'll cause withdrawal if you begin this too soon. And if you give somebody a medicine that lasts a month that's causing withdrawal, it's difficult to come back from that, and they just sort of have to ride out the withdrawal. There are things you can do for that. That's a little beyond what we're going to talk about today. If you're uncertain if it's been long enough to begin this medication, you can do a test. You can give a dose of naloxone and see if they go into withdrawal. If they don't, then it's probably fine to go ahead and proceed with naltrexone. You can also do an oral naltrexone dose as a test to see if it's going to precipitate withdrawal before you do the injection. There are dosing protocols out there for rapid initiation of naltrexone using other medications to assist in that can sort of circumvent some of this problem, but they're a little complicated, and it's beyond, I think, what we're going to get into today talking about. But just know that I think the takeaway from this is that because of the way the medicine works, starting it can be difficult, especially in uncontrolled settings. So it's easier if a patient's in a rehabilitation program or in a hospital or incarcerated or something like that to begin this medication when you can verify that they've had a period of abstinence from opioids. The oral formulation, although it is approved for like alcohol use disorder, is not superior to placebo for treatment of opioid use disorder, and so it has no FDA indication. So when can this not be used? Well, most of this centers around, have they recently used an opioid, or are they in opioid withdrawal? So are they currently being treated with opioid medications for pain control? Then they can't take this medicine. Are they have active physiologic dependence upon opioids, and they can't take this medication. Are they in withdrawal? Again, they can't. If naloxone or oral naltrexone caused withdrawal symptoms, then they should not take this medication. are their drug screens positive for opioids, then they probably shouldn't begin this medication. Otherwise, allergy to any of the components of the medicine, and severe hepatic impairment would really be the only other significant contraindications to worry about for extended release naltrexone. It's an injection, right? So, and you can be allergic to anything. So hypersensitivity reactions, like allergic reactions, can happen. Not terribly common, but they can happen. Injection site things can occur as well. And there's, as we mentioned earlier, the biggest concern, I think, is that there's this risk of overdose. If there's discontinuation of the medicine and they're not in a good place in their recovery and they return to use, if they miss a dose and again can return to use, or if the patient attempts to override blockade of the naltrexone by taking higher and higher and higher doses of opioids, that's a risk. That's a dangerous situation as well. It's not considered appropriate for pregnant patients, really, because there's more evidence to support the other medicines we're going to talk about today in pregnancy. Has been associated with hepatitis in the past. There is some issues with possible depression or suicidal ideation occurring in the context of its use. It's complex, but that's something just to watch for. And because of the way it works, again, it blocks that opioid receptor and keeps things from binding to it. It can complicate emergency pain control. So if a patient has an injury or surgery or anything like that, and they need they need pain control urgently or emergently, it's difficult. It can be complicated to do that when this medication is on board. So that's extended release naltrexone. Has some upsides, has some downsides. And for some patients, maybe the right choice. We're going to talk now just about buprenorphine, which is the next of the FDA-approved. Oh yeah, sorry, looking at the chat here. So yeah, you can be allergic to anything, right? So it is possible. There was a question there. Can naltrexone allergies be real? Possibly, yeah. And you may also be meaning naloxone, because that's something that we'll talk about here when we talk about buprenorphine. That comes up sometimes clinically. So we'll kind of get to that in a second as well. But buprenorphine is a mu partial agonist. So it's a high affinity medicine. It binds tightly to the mu opioid receptor, but it's a partial agonist. Again, meaning it like turns the receptor on 40 to 50%, not 100%. And what this does is it decreases craving for opioids. It decreases withdrawal symptoms. It displaces other opioids from the receptor and prevents them from binding to it. And because it's only a partial agonist, it can have a negative effect on respiratory drive, but there's a ceiling effect on that. It has a limited effect on that, not as much as full agonists like oxycodone and heroin and fentanyl and all these things would have. So less risk of respiratory suppression, but not no risk. And as we talked about before, it does maintain physiologic dependence upon opioids. So if a patient is opioid dependent and they are on this and they switch to this medication, it will maintain some of that protection they had from their increased level of tolerance. Downside to that is if they stop this, they may go into withdrawal. Although usually not suddenly. It takes several days typically for patients to go into withdrawal from buprenorphine. Additionally to its action at the mu receptor, it's a kappa antagonist. And so this is a receptor that's involved in stress systems in the brain. The ligand, the thing that binds to it in the brain usually is dynorphin. It's just a stress hormone, you can think of it as. And so what this does is it blocks that receptor. And this may have some amount of antidepressant effect. Some patients will say they take this and they feel better, right? It interrupts some of that stress pathway that we talked about earlier in that second part of the cycle, and can decrease stress-induced drug-seeking behavior, stress-induced craving, right? So it has this kind of dual action here, targeting multiple different parts of that cycle of addiction. Typically, it's combined with naloxone, which is a potent high affinity mu antagonist. So that's Narcan, right? So that's well, I should say it's the same medication that's in Narcan. So naloxone is a thing that will bind to opioid receptors and sort of like kick everything else out, like remove other things from the opioid receptor. For Narcan, that's used to reverse overdoses. Here, it's included in the combined products with buprenorphine, like Suboxone or Zubsol, and to be a deterrent to misuse. So this decreases the likelihood that patients are going to inject or snort. It does not eliminate the possibility that they will do that, but it decreases the likelihood. It's kind of a deterrent because the patient knows, right, that if they inject this, the naloxone will be active and it may precipitate withdrawal. And so it's included as a deterrent to misuse in the combination buprenorphine naloxone products, which are the most commonly used tablets and films. And so again, the same chart or graph here, like buprenorphine binds tightly to the receptor, but it stimulates it with a 40% intrinsic activity. So it's like a dimmer switch, so to speak. All kinds of things it is demonstrated in terms of positive outcomes. Reduced all-cause mortality, reduced overdose risk, reduced injection use, illicit opioid use, improved retention and treatment, and enhanced quality of life. We'll look at just a few things specifically here. So this is from a study looking at mortality risk and comparing folks who were being treated with buprenorphine to folks who were not being treated with buprenorphine, who had opioid use disorder. And in treatment, the rate here was 4 per 1,000 person years, and out of treatment, it was 9.5, right? So there was a greater than 50% reduction in mortality risk for the folks who were receiving buprenorphine treatment as compared to those who were not. And that's been found in other trials too. This is from a study that looked at retention and treatment. And so what you may or may not be familiar with looking at these kind of charts, these kind of graphs, but basically the steeper the line drops off here, the worse in this study anyway. And so this is the control group with the squares where the line drops off very steeply. That's the people who were not receiving buprenorphine. And you can see that they did not remain in treatment very long. Each square is a person who dropped out of treatment. And the majority of them dropped out of treatment within the first week to 2 weeks. And then all of them were had fallen out of treatment by day 60 or so. As compared to buprenorphine, where at the end of the year-long study, the year that they tracked these folks, 75%, 15 of the 20 were still in treatment. So, dramatically increased retention rate in this admittedly kind of small study. But again, this has been found, and you see it clinically too. I mean, buprenorphine helps people stay in treatment. This is looking at use, just opioid use with and without buprenorphine treatment. And you can see that, we're looking at different studies. The exact effect is variable, but, replicated from study to study that there's a statistically and clinically significant decrease in opioid use that's associated with buprenorphine treatment as compared to placebo. So it helps patients reduce opioid use. And there's a lot more evidence base out there to support its use, but just that's a sampling of it. But just to know that it's well supported by the evidence that all these outcomes are robustly associated with buprenorphine treatment. It's a long-acting medication. Usually you take it every day, but it can be taken every other day if you adjust the dose upward, or you can even take it 3 times a week, and it can work as well, just because it has such a long half-life. And a long half-life is good in this setting because you don't have to worry as much about missed doses. If a patient runs out of the medication, they're not going to immediately go into withdrawal. In my experience, it's day 4 or 5 before they really go into withdrawal when they've stopped buprenorphine suddenly. So that's an advantage of the medication. It does mean that the initial dose titration the full effect of that may not be felt for at least several days after beginning the medication. It's available in a lot of different formulations. They're all absorbed, most of them are absorbed transmucosally, so across the mucosa of the mouth, right? So underneath the tongue, inside the cheek, something like that. Most of them are sublingual, meaning they go under the tongue and have to be dissolved underneath the tongue to be absorbed. If you swallow them, the absorption is really poor, and you don't really get much medication if you just swallow the tablet or the film. So it really does have to be dissolved underneath the tongue, and that takes a while, right? So that's something you have to teach patients, and they have to make sure that they're doing correctly. They need to not drink, smoke, or eat, before or after, right, their dose. And given that the medicines take at least 15 minutes, sometimes longer than that to fully dissolve, sometimes it's 20 to 30 minutes seems like, that it's a commitment, right? And it's something that the patient has to make sure they're doing correctly to get the full effect of the medication and maintain good blood levels so that they can be adequately treated. But there's generics available of both a single mono product, right? So buprenorphine by itself, and the combined product, buprenorphine and naloxone. Most of the time you're using the combined product, buprenorphine plus naloxone, again, because the naloxone is a deterrent to misuse. Typical dosing for that is, somewhere in the range of 16 milligrams a day is a pretty common dose. There are instances, I'm just looking at the chat. I'll come back to your question in a minute. Yeah, I mean, there are instances where you don't want to use the combined product, right? And one of those is when there's a well-documented naloxone allergy. I would say that's rare, but not impossible. And that would be something you would want to verify because buprenorphine has some street value, and the mono product is often preferred to be misused, right, as compared to the combined product. So, but a true naloxone allergy is possible, and it's something that you would want to consider if you're deciding between the mono product and the combination product. But otherwise, I mean, generally you use the combination product. There is a long-acting available form of buprenorphine available as well. The brand name is Sublocade. This is a once-monthly subcutaneous, so under the skin injection in the stomach that you begin with at a high dose and can kind of decrease the dose to a lower maintenance dose. Again, it's once a month, and it replaces the sublingual buprenorphine that the person was taking. They have to be on at least 8 milligrams of the sublingual buprenorphine for at least a week before they can start this. But for many people, it's a nice change because they don't have to think about taking medication every day, which from the clinician side, you don't have to worry about misuse or patients missing doses or diversion of their pills or anything like that. From the patient side, it's just a little bit easier, right? If they don't have to remember to take their dose every day, or they don't have to wait for it to dissolve underneath their tongue, every morning for extended period of time. And also I think it helps them not think about their next dose, right? And that's part of addiction too, right? It's this sort of like obsession, right? Of thinking about like, when's the next thing I'm going to use, right? And this can help them remove themselves even a little bit more from that mindset, I think, where you're kind of focused on what the next dose is. So it can represent another step, I think, in recovery for some patients. I got a question in the chat here about increasing fentanyl use and the impact of this on the brain as the use of buprenorphine decreased due to the sealing effect of the medication. So are you talking about the illicit use of buprenorphine, or? And you can unmute and talk if you'd like. Oh, okay. So no, I don't think so. It has. So you're saying no? You're asking about like prescribing of buprenorphine. Has that been decreased? Because
I was wondering. I work at a medication-assisted treatment program, and so I've just been trying to kind of see if I've noticed a trend. Yeah. But it just seems like with the increase of fentanyl use, that the buprenorphine just isn't stimulating that receptor the way it should.
Well, it is. I mean, it is a step down, right, in terms of like how much it subjectively does. So patients, it's a partial agonist, right? So there's going to be less. Patients are going to feel less from it, which is part of the reason we use it, right? But they're going to feel less from that than they would from fentanyl. The thing I've seen is not so much that where people are deciding not to use buprenorphine, is that they're having difficulty beginning it because of fentanyl. So fentanyl hangs around a long time in the body, or at least it can if you use it often in high doses. It kind of dissolves into the fat tissues. It's lipophilic, and so it can take a while for it to get out of the body, and so that complicates the beginning of the starting of Suboxone or starting of buprenorphine. And so that's led some folks to kind of create new ways of starting buprenorphine, and as opposed to the standard induction process, doing like microdosing protocols, and that's been a little more successful. We've had difficulty in patients who are primarily using fentanyl and using it pretty heavily, starting buprenorphine. But if you can get them over that induction hump, over that first week or so, it seems to work. Yeah, so somebody here is just kind of echoing that and saying yes, it was a struggle getting through that initial withdrawal and getting stabilized in Suboxone when using fentanyl heavily before that. So we've seen that clinically. Microdosing protocols, which I'm not going to cover today, it's a little detailed, but that's out there in the literature and seems to work, at least for some folks, to create an easier transition onto buprenorphine. All right, and so precautions and warnings. It is an opioid, right? So a lot of this is just things that are possible with opioids. So respiratory suppression can happen, overdose can happen, although it's usually not buprenorphine by itself. It's usually buprenorphine in conjunction with another sedating substance. So benzodiazepines, less commonly barbiturates, alcohol, things like that are usually what's found in combination with buprenorphine if there's an accidental overdose. There's a risk, if somebody is exposed to this and they're not opioid dependent, right? That can be dangerous. So again, pediatric exposure can be dangerous. So these medications have to be secured and kept responsibly and away from children and pets and people who do not have opioid use disorder. It is misused and diverted. That's really an argument about that. That does happen. So that's something that has to be considered as a possible risk, with this medicine. It does maintain physical dependence, right? And we talked about that. That has both upsides and downsides. The downside is that if you stop this, you can experience withdrawal. The upside is that it does protect. It is somewhat protective, and that it maintains tolerance. And so, if somebody abruptly stops this medicine, they do at least have some physical dependence and tolerance remaining that might decrease the risk of an accidental overdose if they return to use. Because of its pharmacology, where it's a partial agonist and displaces other opioids from the receptor, it can precipitate withdrawal if it's started incorrectly. So if you start it too soon, and or like we're talking about with fentanyl, like if that's been part of the problem there, the thing is that it's precipitating withdrawal. We'll talk about the induction process here in a minute, but that can happen if you begin the buprenorphine too soon while still using full agonists. You don't have to wait near as long as you do for Naltrexone, but there is a period of time you need to wait and see withdrawal symptoms start to happen before you can safely begin buprenorphine. You can have allergic reactions to this like anything else. If a person is pregnant and taking buprenorphine, the baby can have neonatal opioid withdrawal syndrome or neonatal abstinence syndrome, but generally considered to be preferable that they be on this, even knowing that, as compared to street use. A whole host of outcomes, I should say illicit substance use, as a whole host of outcomes have been demonstrated to be better for both the mother and the infant when they're treated with MOUD, buprenorphine or methadone, as compared to illicit opioid use. And because again, it's occupying the receptor and only operating at 40% activity, it can make emergent pain control more complicated. A few just medical things to think about, right? If somebody has severely compromised respiratory function, you want to be really cautious, right, with this, because it is an opioid. It can decrease central drive to breathe, right? So it can that has to be considered. And so you may just monitor more closely or use lower doses. Really avoid, the possibility that they're going to be taking any other sedating or CNS depressant kind of substance or medication like benzodiazepines or alcohol at the same time. And then for folks who have severe liver disease, they won't metabolize it well. And so you may need to use lower doses possibly, and you may also need to use the monoproducts and not use naloxone, but that's only for folks who have severe hepatic impairment. And the thinking there is that naloxone is excreted by the liver, right, and can accumulate in people who have severe liver disease, leading to precipitated withdrawal because naloxone is accumulating. So that's another instance where you might consider using the mono product in addition to the one I just mentioned a few slides ago of the true naloxone allergy. So the standard thing to do to start this is an in-office induction. So you instruct the patient to stop taking opioids prior to the induction so that they present to your clinic, in a mild, at least, withdrawal. You can use the COWS, the clinical opiate withdrawal scale, to monitor more objectively, the severity of their withdrawal symptoms. And the period of time that they have to wait before they can begin buprenorphine is variable depending on how long acting the opioids are. So the longer acting that opioids are that they've been taking, the longer they have to wait. So heroin, you might only need to wait 12 to 24 hours before you can begin. Methadone might be 48 or 72 hours or possibly even longer. And then, as I mentioned before, fentanyl has really complicated this and made it more complicated and made this sort of standard induction process difficult for a lot of patients. And so, classically or typically what you see if they're using, so let's say heroin, is they don't use for a day. They come back to the clinic. They're in mild to moderate withdrawal. You start a dose of 4 milligrams of buprenorphine. You reassess in wait a little bit, reassess, do the COWS scale again. If they're improving or at least not getting worse, then you can do a second dose of buprenorphine, another 4 milligrams. And you can keep doing that up to a total of 16 milligrams, although you usually don't need to go that high on the first day. More commonly, in my experience, it's 8 to 12, something like that. And that seems to improve withdrawal symptoms. And then you have them follow up closely, like come back in a couple days or the next day or at most a week later. And you can make dose adjustments from there. Whatever they took on that first day would be the total dose they would take on day 2. And that's sort of the standard kind of induction process. There are protocols for at-home induction. So the American Society of Addiction Medicine has published those. And you can find them online, or I can send them to you if you want them. But we've done a lot of at-home inductions, and it seems to work fairly well, especially if it's a patient who's reliable and has some experience with buprenorphine in the past and understands the risk of precipitated withdrawal. That's the big thing you want to avoid. You want to reduce withdrawal symptoms. You want to avoid precipitated withdrawal. You want to get them quickly onto a dose that can be effective for long-term treatment and reduce craving, right? And that can happen pretty quickly. Within the first week, often you're at a full treatment dose and already having hopefully eliminated withdrawal symptoms and significantly reduced craving. Headaches and sweating, nausea, and constipation are pretty common. You can give adjunctive medicines for these things. I've used clonidine some for sweating. You can use, there's a lot of different things you can use for nausea and constipation, but those are common, opioid side effects really. And less common things, but I've seen all of these things, insomnia, agitation, oral pain of various kinds. So like tongue pain, gum pain, lip pain, people will talk about, just irritates some of the oral mucosa. I think that's just because it has to dissolve for so long. It can cause some irritation there, dry mouth. I've heard from some folks. Edema, peripheral edema, and then rhinorrhea and increased lacrimation. So like I said, you can quickly get somebody on an effective maintenance dose of buprenorphine. And then really what you do from a medication standpoint, much of the time after that is you're trying to manage side effects and make sure that they're continuing to do well on their current dose. This is the COWS scale I mentioned before. This is the standard thing for monitoring opioid withdrawal symptoms. And before we move on to methadone, just people ask, like, how long should I take buprenorphine for? Well, there's really no answer to that question. There's really no evidence-based answer to the question. It's an individual decision, that's collaboratively made between a prescriber and the patient. I don't think there's any fixed point at which you can say you've been on this long enough, you need to stop, as from a prescriber to a patient. If it's working, and they're tolerating it, and it's helping to keep them in recovery, I don't really see a reason personally for somebody to have to stop taking it. There are instances where, patients are not taking it and diverting it and misusing it, and that's a different kind of question. But if somebody's benefiting from it and tolerating it, I don't think there's really a reason to say, because there is no timeline at which we can say your opioid use disorder has been cured and now you are fine. And we know that if we stop this, you won't return to use. And the risk of that, the risk of return to use and possible overdose and all the associated morbidity and mortality risks that come along with that is substantial, and never, as far as we can tell, fully goes away. So that is something to consider and weigh against the risks of continuing to take the medication. So what I do with patients is ask them if they've been in a prolonged period of years-long recovery, and they're engaged in recovery activities like meetings and things like that, and they have sort of entered into functional recovery where their personal life and their employment and their are fairly stable, and they're no longer in having these legal problems, and their health is good, and psychiatrically they're from a psychiatric standpoint they're doing well across the board. That person who's been in recovery for a few years, I might ask, did you ever think about stopping the medication? What are your thoughts on that? Just kind of see what they think. I don't think it's something to push somebody to do. I've had patients elect to come off the medication just because they felt like that was the next step for them in their recovery. We talk about the risks of that, and we sort of help them through that process by going really gradually and maybe increasing the amount of monitoring we're doing, or increasing the amount of psychosocial support that they're receiving. So it's an open kind of question, and I don't think there's any definitive answer. I think it just needs to be a patient-centered, collaborative kind of decision-making process that carefully weighs the risks and benefits of stopping and potentially returning to use versus continuing medication treatment. So we'll talk about methadone now. It's the last of the medicines we're going to talk about today. This is a mu opioid receptor full agonist. So it occupies the receptor, prevents other things from binding, maintains cross tolerance, reduces craving, reduces withdrawal, lots of positive things, right? It's associated with basically all the same benefits buprenorphine showed a few minutes ago, but a few other ones as well. It has decades worth of evidence to support its use in heroin addiction and just opioid use disorder generally. The big barrier to it is there's a few pharmacologic things that are specific to the medicine that make it complex to use. But also it's for opioid use disorder treatment, it can only be dispensed from federally licensed opioid treatment programs. So this is not something that's prescribed and picked up at a pharmacy, right? You have to go to a methadone clinic typically every day to receive your usually liquid dose of methadone that you take while somebody's observing you, and you go every morning, first thing in the morning usually. That's a barrier to some folks, right? But it's a full agonist, so it binds tightly to the receptor and stimulates it at 100%. And again, lots of benefits. So reduced mortality, reduced overdose risk, reduced HIV seroconversion, reduced injection, illicit use, criminal behavior, and keeps people in treatment and enhances overall quality of life. This is a review that looked at like mortality data and just showed, this like decline, and on the x-axis here is time since beginning methadone, right? So you can see that declines and continues to decline for an extended period of time when patients are on it. It's variable how much, depending on the study you look at, but it's a pretty consistent finding that mortality is decreased by methadone treatment. This is use, looking at a number of different articles from the early 90s through the late 2000s, and variable again in terms of how much it reduces opioid use, but consistently reducing opioid use as compared to a control group, which is often placebo, is usually placebo in all these different studies. The red line is the control group, the blue line is the methadone treatment group. So use is reduced in many of these cases by 20%, 30% or more. It requires kind of a lot of monitoring, and the dosing is complicated. So it has a long half-life, but it's really variable. Like it depends on the person how they metabolize it. On average, the half-life is 24 hours, so that's good. It's a long half-life. That's a good thing when we're thinking about maintaining somebody on a stable dose. The oral How much you can absorb really varies a lot. So that's another complex thing from person to person. It has a lot of complex or a lot of possible drug-drug interactions. It's metabolized by these enzymes, 3A4, 2B6, and 2D6 that are often affected by other medications in terms of being turned on or turned off or turned up or turned down. So there's a lot of potential there for other medications affecting methadone levels. And so the takeaway from all that is that you have to start low, because you don't want to overdose somebody on it. It's a full agonist, right? You don't want to overdose somebody on it. And it may take longer to get, and you have to kind of gradually increase, right? Because, the steady state isn't reached for like 5 days. You can only change the dose every 5 days or so. So it takes longer to get to a therapeutic dose than with buprenorphine, right? Whereas buprenorphine, it's often within like a week, sometimes even less than that. But methadone is weeks to months, really, to get to a really like good maintenance dose. So this is just a chart demonstrating that the methadone dose doesn't stabilize till about 5 days after it started or a dose is changed. So you can't really tell like what the new dose is going to be like until about 5 days after making that dose change. So that slows down the escalation of the dose too. Typically, you're starting like 30 milligrams a day, and treatment doses may be over 100 milligrams a day. So it really can take a long time to get up to an effective therapeutic dosage. It's indicated for folks who have opioid use disorder and have had at least a year of ongoing active opioid addiction, and who can consent, right? So it's really, as long as you've had this problem and it's gone on for more than a year, you meet criteria. If you're pregnant, you've been on methadone before, or you just were released from prison, you can kind of waive that 1 year timeline requirement. Minors can take this, but they have to have documented unsuccessful treatment attempts other than methadone in the last year, and their parent or legal guardian has to consent. It's an opioid, right? So it can cause respiratory suppression, especially if it's combined with other CNS depressants like benzos or alcohol. Can result in accidental overdose. Accidental ingestion by somebody who's not opioid dependent would be really dangerous or potentially dangerous. It has potential for misuse and diversion, but as I mentioned, methadone clinics are often only giving you the dose that you take right in front of them. That's usually liquid to decrease the chance that you might cheek the pill and take it home and do something else with it. So there are things put in place to help make misuse and diversion harder, but not impossible. Again, maintains physiologic dependence, which has upsides and downsides, is associated with adrenal insufficiency. Has been associated also with some QTC prolongation and associated arrhythmias. So that's something to consider, especially if taking other medications that can cause QTC prolongation. And like any opioid, if you're pregnant and taking this, the baby may have opioid withdrawal syndrome. But again, evidence seems to support that it should be used in pregnancy anyway, as it's safer for the mother and for the baby than illicit opioid use. All kinds of drug-drug interactions. I'm not going to belabor this. I don't think most of the audience here really is going to care about the details of this, other than to know that there's a lot of medicines that this population of people will commonly be taking that do interact with methadone. So antidepressants, anti-epileptic medications, antiviral medications, antibiotics. There's a lot of things that are going to be commonly used in this population that have possible serious drug-drug interactions with methadone. So it just has to be monitored closely, right? And great care taken. Typical opioid side effects for the most part: constipation, nausea, sweating, sexual dysfunction, drowsiness, weight gain. So this is a lot of the stuff that happens with a lot of opioids. And again, as the physician or nurse practitioner or physician assistant or whoever is doing this, like once you get somebody onto that stable therapeutic dose, and even before then, a lot of the time you spent talking about medications is talking about medications to address side effects. So on day one, you begin no more than 30 or 40 milligrams. You observe them often in between doses on that first day. They come back the next day, and you begin slow titration upward. You can increase, every 3 to 5 days by 5 to 10 milligrams. Maintenance doses are almost always 60 milligrams or higher. Average is probably 80 to 120 milligrams. It's something that the patient has to come to the clinic usually every day, at least until they've been stable in recovery for a while, and they can start to earn some take-home doses. But otherwise, they're coming to the opioid treatment program, the methadone clinic, daily to get their dose. The targets here are to not overdose the patient, so don't sedate them, right, and don't put them at risk of respiratory suppression. Decrease withdrawal, hopefully eliminate withdrawal eventually, and decrease craving, right, so that they can again put energy and focus into functional recovery. Longer is typically better in terms of how long people take this. So longer lengths of stay are associated with superior treatment outcomes. That's been demonstrated lots of times. That's not terribly surprising, right? Again, this is a chronic condition we're treating, requires oftentimes ongoing, sometimes even indefinite treatment. And you want to, again, like similar to buprenorphine, if you want somebody who wants to stop, you need to gradually taper their dose, do it over the course of months. This is not something you can do fast, right? And so 5% to 10% dose reduction every few weeks, something like that. That's and you check in frequently, right, throughout that process. You're still doing drug screens, you're still meeting with them, they're doing all their recovery activities, psychotherapy, 12-step meetings, whatever those might be. And you can always go back, right? You can always stop the taper and go back up. And I don't do a methadone treatment. I don't work in an opioid treatment program, but with buprenorphine, I can tell you that a lot of times patients think they want to stop taking medication until they start to see what that's like. And then they get halfway through the taper, and then they realize, maybe I do want to continue taking this. And I don't want to jeopardize all this progress I've made in recovery. And they decide, let's stop here or go back up. That's a pretty common thing that I see. And you can also switch to one of the other medicines. If for some reason a patient is just not tolerating methadone, that it's not working for them, you can think about buprenorphine or extended release naltrexone and instead. So just a few words about comparing medicines sort of head to head. And this, we've talked about basically all this throughout, but just to summarize, right? Methadone and buprenorphine. So methadone is here on the left, buprenorphine's in the middle, and naloxone's on the far, or extended release naltrexone's on the far right, have variable benefits. Methadone and buprenorphine are similar, right? And they treat withdrawal, decrease craving, treat pain, reduce infections, reduce crime, and reduce mortality, right? You don't have to go into withdrawal at all to start methadone, right? To start buprenorphine, you need to see some mild withdrawal symptoms, but they're not going into full-blown withdrawal. They don't need medically managed withdrawal before they can begin buprenorphine. They just need to have a brief period of abstinence from their drug that they've been using. And so those are similar, right? And have some individual kind of nuances we talked a little bit about here today, but have a lot of the same features. Now, extended release naltrexone, does have evidence that it can decrease use, right? Remember, and improve retention and treatment, but doesn't treat withdrawal. Usually doesn't decrease cravings. There's some debatable evidence out there about that and reports from patients, but I'm not convinced. And nowhere near as good at reducing cravings as buprenorphine or methadone. Does not treat pain. We don't know, right? Does it reduce mortality, reduce infection, or reduce crime? I mean, there's reason to think that it would if it's reducing use, but that necessarily hasn't been demonstrated in the literature to the same degree that buprenorphine and methadone have shown that. So, there's different upsides and downsides to each one. Some patients just don't want to take buprenorphine or methadone. They just that's not what they see as part of their recovery. And they choose extended release naltrexone, and that's fine. You can talk to them about the risks and benefits of that and make an informed decision. That can be a valid decision for some folks. And an example of that, I think, is as somebody who's been ordered a treatment by the board or the court or something like that, like the medical board, and they're not allowed to take buprenorphine or methadone, or the court system is like mandating treatment, but not not on board with methadone or buprenorphine treatment for some reason. And so that person, that might be the only medication option for them. But again, some patients just, having free choice of all these things, decide, I want to not be on any opioid at all, and I want to do extended release naltrexone. There is a trial, and the slide's kind of messed up here, sorry about that, but the extended release naltrexone was compared to Suboxone, to combined buprenorphine naloxone treatment. It's called the XBOT, which is a cool name, but XBOT trial. And so they looked at a lot of things, but this is relapse-free survival on these curves. So basically, not like death, but like how long did they go before they returned to use? And you can see on the x-axis here, time, right? So in weeks. So how long did the patients go? And this is a proportion of the patients on the y-axis from 0 to 100%. How long did they go before they returned to use? And so this blue line is the buprenorphine naloxone. So that's the combined buprenorphine product, right? And so you can see that in the entire population of this study, on the left here in chart and graph A, that performed better than the extended release naltrexone. However, remember what we talked about with extended release naltrexone, that it's difficult to start. So if you remove the people who just weren't able to start extended release naltrexone because they couldn't tolerate that initiation process, or they had to wean off of opioids for a week or 2 weeks, if you remove those folks from this study, then and only include the people who successfully began naltrexone, then it's pretty identical, right? There's not really a statistically significant difference here between the outcomes for the buprenorphine naloxone patients and the folks who were able to begin extended release naltrexone successfully. So that's interesting, right? But underscores that there are a group of people who just have a really hard time starting this medication. But if you successfully do start it, at least while they're taking it, it can have some benefits in terms of use comparable to, at least in this one trial, to buprenorphine naloxone. So in summary, these are 3 medications that are FDA approved for opioid use disorder. They all work at the new opioid receptor, but in 3 distinct ways, right? Methadone's full agonist, buprenorphine's partial agonist, naltrexone's a full antagonist. And they have demonstrated various improvements in outcomes. Methadone and buprenorphine more than extended release naltrexone, but still evidence-based benefits for it as well. And really, based on the evidence, these should be an integral component of treatment for patients with opioid use disorder, and should be utilized in this population more than they are. So, having said all that, there's resources or sources on the, from the articles and things cited here.